Thank you for the invitation to this fantastic country, India, and very nice to be here. So for the next few minutes, I will present the global consensus on optimal exercise recommendation for enhancing healthy longevity in older adults with sarcopenia. This consensus integrates decades of research to address a critical intersection between sarcopenia, diabetes, and aging. So let's explore how tailored exercise can transform outcomes in this vulnerable population, and I also hope that you enjoy my Spanish accent. So in the recent international exercise consensus just published 2 weeks ago, we provide an evidence-based rationale for using exercise and physical activity for health promotion and disease prevention and treatment in older adults. So exercise prescription in this case is discussed in terms of the specific modalities and doses that have been studied in randomized controlled trials for their effectiveness in attenuating physiological changes of aging, disease prevention, and or improvement of older adults with chronic disease and disability. Thus, this consensus aims to enhance the efficacy, applicability, and comprehensiveness of exercise programs to better meet the current health challenge of older individuals face. So the human aging process is universal, is ubiquitous, inevitable, and decremental. Every physiological function is being continually diminished, and at around 20-30 years of age, humans have acquired all the physiological development that they will attain. From that stage, the aging process commences, although the rate of change is very heterogeneous. This process will continue up to 6 or 7 decades, ending in death. Evidence shows that being physically active and having a healthy diet coupled with no smoking and moderate alcohol consumption are integral to the maintenance of health and well-being in old age. In this is the best karma to prevent disease. The left-hand side shows a probable pathway for non-exercisers. These individuals are susceptible to exercise associated and also disease not associated with physical activity. Various pathological processes can cause physiological disruption. Exercise as therapy can potentially reverse some declines, but issues related to low cardiorespiratory fitness, low VO2 peak, muscle strength, power mass, low muscle mass, and functional capacity values may persist. The right-hand sides illustrate the role of physical activity as preventive medicine, emphasizing the preservation of effective, albeit gradually diminishing physiological functions. They are partially protected from exercise-associated diseases, but are equally prone to disease unrelated to exercise. Both cohorts are experiencing constant decremental changes because of the inherent aging process, but at different rate due to their physical activity engagement. Sarcopenia, everybody here knows that affects between 10 to 7% of adults over 60, rising to 50% of those over 80. It is not just muscle loss, it is a driver of fragility, disability, and mortality. In diabetic population, insulin resistance accelerates muscle wasting, creating a vicious cycle. Addressing sarcopenia is non-negotiable for healthy longevity. Sarcopenia in diabetes is fueled by chronic inflammation, mitochondrial dysfunction, and anabolic resistance. Hyperglycemia impairs muscle protein synthesis, while neuropathy and vascular damage exacerbate functional decline. Exercise disrupts this cascade by targeting molecular pathways like mTOR and MPK. Both structured exercise and overall physical activity play important roles as a preventive strategies for many chronic diseases, including cardiovascular disease, stroke, diabetes, osteoporosis, and obesity, improvement of mobility, mental health, and quality of life, as well as reduction of mortality among other benefits. Notably, exercise intervention programs improve the hallmarks of frailty, low body mass, strength, mobility, physical activity, and cognition, optimizing functional capacity during aging. Physical activity, also particularly exercise, can reduce the burden of comorbidity, disability, and premature death caused by incident disease, and is valuable for primary, secondary, as well as tertiary preventions. The figure that we saw in the consensus show the major disease and syndromes for which exercise could serve as a preventive strategy or aid in disease prevention, secondary and tertiary prevention. The WHO recommends actively addressing these issues to promote healthy aging. Although the specific mechanisms and ultimate modalities of physical activity health benefits are not fully understood, evidence to date suggests that engaging in physical activity can sustainably enhance domains of intrinsic capacity. This, in turn, reduces mortality, promotes functional ability, and also healthy aging. However, not all physical activity is equally effective, as dose-response relationships and exercise modality-specific adaptation exist. There are associations between intensity, volume, and modality of exercise and many health outcomes. In a recent study, it has been shown that intensity distribution of physical activity may be more important for mortality reduction than the volume, and integrating physical activity of higher intensity into daily routines may optimize health. The modality of physical activity performing is also critical for intending health outcomes beyond mortality, as many exercise adaptations are modality specific. For example, for over 3 decades, anabolic exercises, such as high resistance training, has been recognized vital for maintaining or enhancing functional capacity in older adults, particularly those who are frail or with conditions as sarcopenia and osteoporosis, mobility impairment, or those hospitalized in resident care. Indeed, we saw 20 years ago that the progressive strength training program may lead to recover 20 years of functional capacity. In a couple of recent studies that we have performed in our hospital, published in JAMA Internal Medicine, our research group explored the possibilities of modifying traditional models of hospitalization in acute care of older units, but goes a step further by adding the individualized and adapted prescription of multi-component exercise to each patient. Our studies show that an individualized multi-component exercise intervention, including high-intensity resistant training exercise, performed during only 5 to 7 days, provides a significant benefit over usual care and can help to reverse the functional decline associated with acute hospitalization in older adults. Also, an individualized multi-component exercise training program with a special emphasis on muscle power training was shown to be an effective therapy for improving lower extremity muscle power production at maximal loads and maximal strength in diabetic and oncology older patients during acute hospitalization. We have also shown in the mid-frail study, a cluster randomized multicenter clinical trial conducted in more than 70 trial sites across 7 European countries, that we recruit 964 participants, good results. We aimed to evaluate the effectiveness of a multimodal intervention on functional performance in frail and pre-frail participants aged more than 70 years with type 2 diabetes. We have demonstrated that a 12-month structured multimodal intervention program across several clinical settings in different European countries led to a clinically relevant and cost-effective improvement in the functional status of older frail and pre-frail participants with type 2 diabetes. Everybody knows already that skeletal muscle mass has been described as an endocrine organ that can produce and release myokines into the bloodstream, where they function locally or systemically to elicit a myriad of beneficial effects, including decreased inflammation and insulin resistance. The anti-inflammatory milieu created by exercise training is believed to be mediated largely by myokines, which protected arteries against the progression of atherosclerosis and stenosis, and also preserves the stable phenotype of pre-existing atherosclerosis plaques. In this context, low muscle strength in adults is associated with the development of cardiovascular disease and cardiovascular disease-related outcomes, including death. In turn, the strength of skeletal muscle largely depends on its mass. And low muscle mass is similarly associated with an increased risk of cardiovascular or related outcomes, especially in older individuals. Because skeletal muscle mass is the major site of dietary glucose utilization and myokine production, loss of this tissue contributes to dysglycemia and insulin resistance, as well as myokine dysregulation, which in turn are associated with mitochondrial and endothelial dysfunction and left ventricular hypertrophy. The good news that we have is that resistance training has a tremendous therapeutical potential, particularly in patients aged more than 60 years with cardiovascular disease, as it can counteract loss of skeletal muscle strength or mass while improving at the same time glycemia control and decreasing visceral fall. Indeed, increases in muscle strength resulting from resistance training might also prevent cardiovascular disease itself. Physical exercise training favors large and positive change in exercise concentrations in adults living with type 2 diabetes. Changes in those exercises are related to improvements in clinical metabolic parameters, as glycated hemoglobin, waist circumference, and body mass. We recently identified an optimal dose for exercise prescription in this clinical population. An optimal dose for exercise prescription, any form of exercise at moderate or vigorous intensity, with a program lasting longer than 24 weeks, with at least 3 sessions per week and more than 60 minutes per session, induce significant improvements in exercise in adults living with type 2 diabetes. In turn, these changes are associated with improvements in clinical metabolic parameters. In the recent international consensus statement, we provide an evidence-based rationale for using exercise and physical activity promotion and disease prevention and treatment in older adults. Actually, the utility is fivefold: to exploit its potential to prevent disease, but also to serve an adjunct to effective medical and surgical interventions, to substitute for harmless treatments, to counteract side effects, as well as to become the mainstream in the management of conditions for which there is no other effective treatment. Indeed, actually prescribing non-evidence intensity and volume should be similar to use the placebo and suboptimal medication dosage, especially concerning progressive resistance training, where often low intensity and non-progressive exercise is prescribed. This figure also compares the efficacy of exercise and pharmacological treatment across 4 healthy domains critical to aging populations. Exercise demonstrates superior effectiveness in managing sarcopenia, frailty, and functional decline, while pharmacotherapy excels in acute symptomatic conditions like hypertension. Integrating both strategies optimize outcomes for chronic disease such as diabetes and osteoporosis. Indeed, we don't have medications that improve physical fitness, functional capacity, or alleviate fragility. In an aging population, polypharmacy and chronic disease management are also critical concerns that significantly impact health outcomes. The intersection of medication and the use of physical activity and exercise offer a promising approach to enhancing the well-being of the older adults. An integrated strategy that combines exercise as well as pharmacotherapy can optimize the vitality and functionality of older people while minimizing adverse drug reactions. For example, we know that aerobic exercise can reduce the severity of depression and anxiety, often managed with psychotropics, while improving cardiovascular health. Also, resistance training can mitigate the muscle wasting effects of corticosteroids and enhance bone density, while simultaneously addressing primary and secondary health concerns. Metformin's blood aerobic gains and muscle gains, while compensating with high-intensity interval training. GLP-1 agonists aid weight loss but risk muscle wasting, countered with high-protein diets and progressive resistance training. So exercise let us reduce insulin doses while improving glycemic control. The BB-Frail multi-component program that tomorrow we will give a short workshop on this topic is a good example, an excellent example of an evidence-based program. These multi-component programs include flexibility, resistance training, balance exercise, and cardiovascular activities that are customized to the individual's functional capacity. BB-Frail is an example of a program that meets this criteria and has been shown to be effective in promoting physical function and reducing falls and frailty in older adults. To summarize, a healthy lifestyle can add years to life and also life to the years, and it is in our hands. Exercise is not a single medication, but should be seen as a medical intervention with a myriad of modes and dose combinations, which have highly differentiated effects on the body's system. The treatment with physical exercise should be chronic, with an adequate dosage that is never just walking. We are not made for exercise to be a pastime. Indeed, it's something that we do to survive. Physical exercise as medicine is much more than just walking, which is not enough, and it shows a dose-response effect and can be individualized. So the lack of the adherence to evidence-based exercise intensities and volume is equivalent to the unacceptable practice of prescribing ineffective doses of medication. In pharmacology, the placebo effect is often avoided, but it seems to prevail in exercise prescription, especially concerning resistance training. Also, as a practical application of the consensus, I would like to give you some tips. Progressive resistance training is the primary approach. Start early and prioritize intensity training between 70 and 80% of 1 RM for optimal benefits. Incorporate also aerobic resistance and balance exercise to enhance overall physical function. Evaluate for neuropathy and cardiovascular disease, adapting exercise to ensure safety. Leverage apps and wearable devices to monitor progress, improve compliance. Optimizing exercise in relation to pharmacotherapy is very important. Metformin, for example, may reduce aerobic capacity and adaptation to progressive resistance training, and consider high-intensity progressive resistance training or high-intensity interval training can be useful. Also, schedule exercise appropriately after meals to support glycemic balance is important. This is not optimal, it's just a standard care. So, let's make exercise prescription as a routine as metformin, train clinicians, fund community programs, and advocate for policy change. Together, we can turn sarcopenia from a death sentence to a manageable condition. Thank you for your attention.